Imagine you're on shift. You attend to a 15-year-old male. He's sick, pale, and holding his lower abdomen. He says he's had stomach pain for hours. Sound familiar? A key question often overlooked is whether anyone has actually examined his testicles. Welcome to this video. Today we're covering torsion of the testes, one of the most time-critical surgical emergencies seen in pre-hospital and emergency care. Unfortunately, this condition is still missed too often. This isn't just a urology problem, it is very much a paramedic, emergency department and primary care problem, because you are likely the first clinician this patient sees. Your assessment could be the difference between saving a testicle and losing one. So how big a problem is this? Let's look at the numbers. Torsion of the testes occurs in about 1 in 4,000 males under 25 each year. In England alone, there were over 2,200 hospital admissions coded as testicular torsion in a single year. The age pattern follows what we call a bimodal distribution, meaning there are two peak periods. The first is in newborns, and the second, much larger peak is around puberty, typically between 12 and 18 years of age. Around 65% of all torsions happen during puberty. But here's what makes this condition terrifying from a clinical perspective: time. If blood supply is restored within 6 hours of symptom onset, there is roughly a 97% chance of saving the testicle. Beyond that window, the salvage rate drops dramatically. After 12 hours, around 75% of patients lose the testicle entirely. After 24 hours, it's almost certainly gone. And here's the sobering reality: the 2024 NCEPOD report. That's the National Confidential Inquiry into Patient Outcome and Death, published a landmark review called Twist and Shout. They looked at over 800 young people who presented with testicular torsion across the UK. They found that only 73% of patients presented to a healthcare worker within that 6-hour window. Even more concerning, 66% of patients and 35% of parents or carers didn't recognise the symptoms. That delay in presentation is the biggest factor in testicle loss. But delays don't stop at the hospital door. The same report found delays in referrals, senior review, and unnecessary transfers between hospitals. In the Bristol review, which covered 25 years of data, 38% of testes explored surgically were already dead on arrival in theatre. This isn't a rare condition. It's a common emergency with severe consequences if we get it wrong. So let's break down what's happening in the body. Each testicle hangs in the scrotum, connected by the spermatic cord, like a power cable. Inside are blood vessels, nerves, and the vas deferens, which carries sperm. Normally the testicle is anchored in place within a covering called the tunica vaginalis. It's held firmly enough that it can't spin around. But in some people this attachment is abnormally high or loose, a variation known as the bell clapper deformity. The name comes from the fact that the testicle hangs freely, like the clapper inside a bell which can swing and rotate. When the testicle twists, it twists the spermatic cord with it. Imagine wringing out a wet towel. As you twist, the opening gets tighter and tighter. That's exactly what happens to the blood vessels inside the cord. First, the veins get squeezed. Blood can still enter through the arteries but can't leave. The testicle swells with trapped blood. This is venous congestion. As the twist gets tighter, the arterial supply also gets cut off. Now the testicle is completely starved of oxygen and nutrients. If it isn't corrected, the tissue begins to die. Critically, this deformity is present bilaterally in at least 40% of cases. That's why surgeons will always fix both testicles during the operation, even the healthy one. There are two types of torsion. Intravaginal torsion, most common in adolescents and adults, is a twist within the covering. Extravaginal torsion, more common in newborns, involves the entire cord and covering. So what triggers a torsion? Sometimes there's no obvious cause at all. It can even happen during sleep. In fact, several patients wake up in the night or early morning with sudden severe pain. It can happen during physical activity or sport, and occasionally after direct trauma to the groin. Cold weather is also a recognised trigger. The Bristol study found that 24% of torsions happened in December and January. The theory is that the cremaster muscle, which raises and lowers the testicle in response to temperature, contracts in the cold, potentially triggering the twist. The biggest risk factor is the bell clapper deformity. An undescended or partially descended testicle also increases risk, as does having a larger testicle from variation or a tumour. So, symptoms. The textbook case is sudden, severe, one-sided scrotal pain. Patients often call it the worst pain they've ever felt. Nausea and vomiting are very common. Vomiting can be so prominent that clinicians focus on the abdomen and miss the real problem. This is especially true in younger patients who may not mention testicular pain either from embarrassment or not making the connection. And here's a clinical pearl that could save you from a misdiagnosis. Any young male presenting with lower abdominal pain and vomiting should have their testicles examined. Referred pain from the testicle to the lower abdomen is extremely common and catches clinicians out time and time again. Other features you may notice include a testicle that sits higher than normal, high riding testis, a testicle that lies horizontally rather than vertically, bell clapper sign, redness and swelling of the scrotum, and the patient may have had previous episodes of similar pain that resolved on their own. This is called intermittent torsion and detorsion, and it's a major warning sign. So this is where it gets practical, especially aimed at those of you in pre-hospital care. First things first, testicular torsion is a clinical diagnosis. That means you diagnose it based on what the patient tells you and what you find on examination, not based on blood tests, not based on scans. In the pre-hospital setting, if you suspect torsion, that's enough. You need to act. There's a scoring tool called the TWIST score, Testicular Workup for Ischemia and Suspected Torsion. It's a 7-point score based on 5 clinical findings: testicular swelling and a hard testicle each score 2 points. A high riding testicle scores 1. Absent cremasteric reflex when stroking the inner thigh fails to raise the testicle scores 1 point. Nausea or vomiting scores 1 point. A score of 0 to 2 indicates low risk. A score of 3 to 4 is intermediate risk. A score of 5 to 7 indicates high risk. These patients should go straight to theatre without waiting for an ultrasound. A systematic review and meta-analysis published in the Journal of Urology found that the TWIST score had an area under the curve of 0.924, using the Barbosa risk stratification, with the high-risk group showing a positive predictive value of 97.5%. Importantly, a 2016 validation study showed that this score was accurate even when used by non-urologists, including emergency medical technicians. This matters for paramedic practice. You may not use the TWIST score formally, but knowing these 5 features gives you a mental checklist. So what should you do on scene? Let's keep this simple. Take a thorough history. When did the pain start? Sudden? Any past similar episodes? Trauma? Urinary symptoms? Get a precise onset time. The clock is ticking. Examine the patient. This can feel awkward, especially with a teenager, but it is essential. Before starting, explain what you'll do and why. For example, I need to check your testicles because this pain could be coming from there and it's important for your health. Always ask for permission and, if possible, offer a chaperone. Reassure the patient this is a normal medical exam and your priority is their safety and comfort. Look for a swollen, tender, high-riding testicle or a horizontal lie. If trained, test the cremasteric reflex. Do not attempt manual detorsion in the pre-hospital setting unless you have been specifically trained and authorised by your service. In almost all cases, detorsion is performed in hospital by specialist teams. There may be rare exceptions where advanced paramedics with targeted training operate under strict protocols, but this is not routine and depends on local guidelines and authorisation. If you are in doubt about your scope of practice, err on the side of caution. Prioritise rapid transport and do not attempt detorsion in the field. Pain management is important. These patients are in agony. Treat their pain according to your local guidelines. Entonox, paracetamol and morphine are all appropriate depending on your scope of practice. Transport rapidly to the nearest emergency department with surgical capability. The GIRFT pathway, getting it right first time, emphasises that patients should be taken to a hospital where scrotal exploration can be performed on site to avoid delays from secondary transfers. If the nearest hospital cannot perform emergency scrotal surgery, contact your clinical supervisor or follow local guidelines for referral to a regional centre that can. Always inform the receiving hospital of the urgency. If you must go to a non-surgical hospital due to the patient's instability or other concerns, ensure they are pre-alerted about the need for immediate onward transfer. The priority is to minimise any time lost before the patient can access surgical care. Pre-alert the receiving hospital, make it clear this is a time-critical surgical emergency. State the time of symptom onset prominently in your handover. Document the time of onset clearly and repeatedly. Write it on the patient report form and state it in your handover, as this information drives every decision that follows. Also record other key details, your examination findings, such as swelling, tenderness, and the testicles high riding or horizontal lie, the severity of the patient's pain, any interventions performed such as pain relief, and the patient's response. Thorough documentation helps ensure an effective handover and ongoing care. Once in hospital, the definitive treatment is surgical exploration. The surgeon will make an incision, untwist the testicle, assess whether it's still alive, and then stitch it in place to prevent it from happening again. This stitching is called orchidopexy, which is the surgical fixation of the testicle. If the testicle has died, it's removed. That's an orchidectomy, which is the surgical removal of the testicle. The opposite testicle is also fixed in place during the same operation due to the bilateral bell clapper risk we discussed. Manual detorsion can be attempted in the emergency department while waiting for theatre. The classic teaching is to rotate the testicle outward like opening a book, but this doesn't always work and should never delay surgical exploration. This is arguably the most important part of this video, because the biggest danger with testicular torsion isn't that you've never heard of it, it's that you mistake it for something else. The most common mimic is epididymitis, inflammation of the structure at the back of the testicle. This tends to come on more gradually, is often associated with urinary symptoms like burning or frequency, and classically improves when the testicle is lifted, called a positive Pren sign. However, and this is critical, Pren sign is not reliable. Do not use it to rule out torsion. Torsion of the testicular appendage, a small tissue tag attached to the testicle, can also cause acute scrotal pain. This is often seen in slightly younger boys, typically aged 7 to 12. You might see a blue dot sign, a small bluish discoloration visible through the scrotal skin at the upper pole of the testicle. This doesn't need surgery, but you cannot reliably distinguish it from testicular torsion clinically. Other differentials include an incarcerated inguinal hernia, scrotal trauma with hematoma, orchitis, and rarely testicular cancer, presenting with pain. The golden rule is this: if you cannot confidently exclude torsion, treat it as torsion until proven otherwise. It is better to send a patient to theatre who turns out to have epididymitis than to send a patient home whose testicle is silently dying. A few additional points that are worth covering. Even when the testicle is saved, there can be long-term effects on fertility. Research suggests up to 40% of patients may have abnormal sperm function after torsion, even after successful surgical fixation. One theory is that the body's immune system produces antibodies against damaged testicular tissue, which can also affect the healthy testicle on the other side. This is sometimes called sympathetic orchidopathia. Psychological impact. Losing a testicle, particularly as a teenager, can have a significant psychological effect. The NCEPOD report highlighted that follow-up care after orchidectomy is inconsistent across the UK. Over half of patients were not offered a follow-up appointment. This is an area that needs improvement. As the first clinician to see the patient, you set the tone for the entire experience by being sensitive and professional during your assessment. Ultrasound. Doppler ultrasound can help confirm the diagnosis by showing reduced or absent blood flow to the affected testicle. However, a normal ultrasound does not rule out torsion. It is operator dependent, and waiting for an ultrasound should never delay surgical exploration in a patient with a clear clinical picture. The NCEPOD report found 18% of patients underwent Doppler ultrasound, and while clinicians reported it was helpful in most cases, the GIRFT pathway makes clear that imaging should not delay definitive treatment. Neonatal torsion. This is a slightly different condition. In newborns, torsion is usually extravaginal, may have occurred before birth, and often presents as a painless, firm, discoloured scrotal mass. Management is debated, but urgent surgical review remains essential. So let's wrap this up with the key takeaways. Testicular torsion is a time-critical surgical emergency. You have roughly 6 hours to save the testicle. It's a clinical diagnosis, history and examination are your most important tools. Any young male with sudden lower abdominal pain and vomiting needs their testicles examined, period. Document the time of symptom onset and clearly communicate it. Transport to a hospital with surgical capability and pre-alert. If in doubt, assume it's torsion until proven otherwise. If you found this video helpful, please do us a massive favour and hit that like button. It genuinely helps more people find this content. If you're not already, please subscribe to the channel and turn on notifications so you don't miss the next one. Share this with your crewmates, your cohort, your study group, anyone who might benefit, and we'd love to hear from you. Drop a comment below and let us know what topic you'd like us to cover next. Whether it's another time-critical condition, a pharmacology deep dive, or a clinical skill breakdown, we're all ears. Thanks for watching, and we'll see you in the next one.